Um, Restrictive cardiomyopathy is always associated with constrictive pericarditis. No, that's definitely wrong. They're two separate conditions, independent of each other. Again, one is pericardial layer, the other is myocardial layer. And again, it's not a common form of cardiomyopathy. Large pericardial effusion is one that's going to have a diameter greater than 2 centimeters. Moderate is 1 to 2 centimeters. Mild is less than 1. And then you can have just a trace pericardial effusion, so just a minimal or trace. So infiltrative restrictive cardiomyopathy is caused by all of the following except. So amyloidosis is going to be your number one reason. You can also have sarcoidosis being another infiltrative disease, as well as glycogen storage disease and hemochromatosis. For this one, our parasternal long axis view, pericardial effusions are usually seen posterior to descending aorta, while pleural effusions are seen anterior, so that's false. Just remember your pericardial effusions are going to be before that descending aorta in our parasternal long view. It's common cause, restrictive cardiomyopathy, amyloidosis, that. Constrictive pericarditis versus restrictive cardiomyopathy. So again, I want you guys to just be familiar with the differences between the two. So they're both considered diseases that affect diastolic, function. Just remember that with constrictive pericarditis, that stiffened pericardial layer, with that, you'll actually have respiratory variation within your mitral and tricuspid inflows. You'll also have pulsus paradoxus. So you can have influence again with your respiratory variation with your pulses and your pressures. So with that, inspiration and expiration will affect your mitral and tricuspid inflows and augment with each. With restrictive cardiomyopathy, you don't have that. Also with restrictive cardiomyopathy, you typically have, or you do have that biatrial enlargement. So there's two large atria. With constrictive pericarditis, the atria are typically normal in size. So this one could be this one was a little tricky. So over here, you kind of have on your side your centimeter markers. You know what? Maybe that person that answered moderate, I can go back and give you guys a point for that. Because It'd be easier if I had my centimeter markers on this side, but if you're in like your clinical test, you can take your little piece of scrap paper and mark off, what 1 centimeter represents, and then take your little piece of paper and line it up here along this pocket of fluid. To see like, what that measures. So it's about a centimeter. Again, sonographic finding for restricted cardiomyopathy. That first thing you look for is that biatrial enlargement. So cardiac tamponade, this is when the pressure in that pericardial space exceeds the pressure within the heart itself, causing hemodynamic changes. So that manifests itself by us seeing that first off right atrial collapse, and then we see right ventricular diastolic collapse. It's a common cause of myocarditis. It's going to be Coxsackie virus. All the following are early findings of cardiac tamponade, except. So if we see left ventricular diastolic collapse, this is what's considered more of a late finding. So at this point, the right side of the heart is for sure hemodynamically compromised. So again, one of the first things we're going to start seeing is our right atrial collapse. Then we'll see right ventricular collapse. And if it proceeds to left ventricular diastolic collapse, that this heart has been very severely hemodynamically compromised at this point. We'll typically see dilated IVC before, any sort of left-sided issues, because that right side of the heart's gonna, again, it's hemodynamically compromised. Things are starting to back up. So we'll wind up, with dilatation of IVC, long before we start developing this LV diastolic collapse. Restricted pericarditis can be caused by all of the above. Constricted pericarditis, stiffening of that pericardium, preventing normal ventricular filling. See if there's anything that you guys got wrong. So this is again our respiratory variation, like with constricted pericarditis and tamponade, what we look for. So I just kind of focus on the right side of the heart first, or for me, it's easier to just memorize what's going on the right side of the heart, particularly because that's the side that's going to be affected first. So if I know the right side, I just kind of flip it for the left side. So with tamponade, I remember inspiration. We're just talking about tricuspid flow now. With tricuspid valve on the right side, inspiration will increase my spectral tracing, or augment, make it larger. So I think inspiration increase, expiration will then be decrease. And then if I'm going to now take that logic onto the left side of the heart, I just kind of reverse it then. Inspiration is going to decrease and expiration is going to increase. So if you remember what happens on the right side of the heart, inspiration increase for tricuspid, mitral is just reverse. You just flip it. That's the easiest way for me to memorize and remember that. And then Beck's triad, when we're talking about cardiac tamponade, it's going to be quiet heart sounds, increased venous pressure, and then decreased systemic blood pressure. So this is now going to our midterm. So with this clip, the first thing I see is that that chamber looks rounded. That LV doesn't have our nice classic bullet shape appearance. It's appearing more oval, more ovoid. So this is would be a classic example of dilated cardiomyopathy. So this is goes into that theory of when we're talking about the sphericity index, or how spherical that LV is becoming now. So that sphericity index could be used to determine, the severity of the dilated cardiomyopathy, and it could be used as, again, as a prognostic indicator to outcomes. So the more spherical that this LV becomes, so typically we have that nice elongated bullet shape, but as it starts to dilate and become more rounded, more spherical, the worse it is, the more spherical it becomes, the worse that dilated cardiomyopathy is, and the worse it is that patient outcome is going to be, the worse the prognostic outcome is for that particular patient. The other thing to also realize, or kind of tell you that this dilated cardiomyopathy is the reduced EF. I mean, you can obviously see that, there's a tremendous amount of blood in that chamber that is not being injected during systole. So that remains. This patient, obviously has a very low ejection fraction based off of this. So don't get also confused. You can kind of see the myocardial layer. So this is all papillary muscle and cord. Takotsubo's. That one's going to look a little bit different. You'll have a diet, so you'll get like hypertrophy and almost a pinching in of the mid cavity segment, and a dilatation up by the apex. So this actually means squid in Japanese. So the chamber almost takes on what looks like a squid-like appearance, where this becomes like the head of the squid, and then a pinching in the body, and then a fanning out down by the base. See if I can ever show you guys a picture of that at some point. But so you guys got all that: mitral prolapse, myocardial expansion, good. Systemic hypertension, coronary artery disease, factor 5, got all right, good. With systemic hypertension, one can expect to see all the following on 2D echo. So with hypertension, something that it could cause is actually a dilated aortic root. So that's something that we worry about with patients with long-standing hypertension, is the potential for dilatation of that aorta and aortic root. In addition, systemic hypertension, we also worry about potential for dissection. So that could be something as well, in addition to that aortic root dilatation. And then we also worry about damage, to the valve itself, aortic valve, as well as, hypertrophy of that left ventricle. So this is wrong. We'd typically expect, that patient's LV mass to increase. We expect a large hypertrophied left ventricle, so the LV mass and mass index will both be increased. We don't expect a hypokinetic heart. If anything, we would expect a hyperkinetic, because those walls have become thickened now, and that chamber dimensions, the internal chamber dimensions, have become smaller. It's good. Necrosis begins 4 to 6 hours. Complications of hypertension include all the following, except, you guys got that right. So all the following are complications of mitral valve prolapse, except so patients with mitral valve prolapse actually are more susceptible to developing endocarditis. So that is something that we potentially could worry about with patients with mitral valve prolapse. Something that they're really not susceptible for then is developing that mitral annular calcification. So that's more along the lines of degenerative diseases, maybe someone that has systemic hypertension that could potentially, lead to the development of our MAC or mitral annular calcification. Necrotic scarred myocardium. So this patient's had an infarct. That myocardium has become scarred now. So with that scarring, again, it's thinner but more dense. So RV ischemia or infarct can result in. So think of this as along the same lines as if the patient had an LV infarct. With LV infarct, we would worry about at that point the potential for mitral regurgitation. So same thing holds true with the right side of the heart. So if we have ischemic heart disease on the right side, right ventricle is not contracting properly, and that can prevent or cause poor coaptation or coming together of those tricuspid valve leaflets, because one segment potentially may not be moving, will prevent the valve from functioning properly and being able to coapt properly. You could potentially also have, dilatation of that chamber, remodeling of that right side of the heart as a result of an infarct could cause separation of those valve leaflets. So same that holds true with the left side, but also hold true with the right side of the heart. So LV and RV infarcts, they're not going to really affect aortic and pulmonic valves. They'll, the main effect is going to be on those AV valves, the mitral and tricuspid. When we're talking about diet drug valvulopathy, this usually affects which valve? That's the mitral. That's associated again with that diet drug fen-phen, which is no longer on the market. The response to pulmonary hypertension on the right ventricle is, so that's going to be right ventricular hypertrophy and dilatation. So just remember, pulmonary hypertension, everything's got to just go upstream. So what's the next most proximal chamber when we're talking about pulmonary hypertension in the lungs, increased pressure in that lungs? That pressure, again, everything just kind of rolls backwards. So what's upstream of the lungs? That's going to be the RV. An aneurysm has the following appearance. So with the aneurysm, we're going to have an abnormal geometry or shape of that chamber in both systole and diastole. So we'll see that aneurysmal segment, that outpatching, as the heart contracts and expands during systole and diastole, it'll remain abnormally shaped. So we'll have that dilatation or that outpatching in both systole and diastole. Not 17 segments. Thick, dramatic. So determinants of LV function include all the following except. So things that will affect our LV function or kind of determinants of LV function, how well the LV functions are going to be things like afterload, as well as our heart rate, and then the contractility of the heart. Wall motion is how we actually describe LV function. So it's not an actual determinant or things that will determine how the LV is functioning. The wall motion describes the LV function. So that one was a little tricky. I'm sorry. Yeah. So that's the one that's is under accept. Kind of like trick myself. I was like, wait a minute, that's the right answer. Or that's the wrong. Arsinoid we know affects the right side of the heart. Tricuspid more common. Which of the following is not a marker of poor prognosis? I think I gave everyone credit for this one. I went back and gave everyone credit. Not a marker of poor is a marker of poor prognosis in pulmonary hypertension. Isovolumic relaxation time and isovolumic contraction times. So you guys just need to be very super familiar with those in your cardiac cycle. Again, isovolumic relaxation time. So all four valves are closed, heart, LV, or the ventricles are starting to relax at that point. So that marks the start of diastole. And isovolumic contraction time, heart is starting to contract. Our pressures are building up, but all four valves are so close that marks the start of systole. So that would be early systole. Got those right, those right. Diabetes is associated with earlier onset of coronary artery disease. This is true. So diabetes affects the arteries. So it'll affect all the arteries in the body, particularly the small ones. It likes to attack those small arteries. So that particularly holds true with the arteries for the heart. So diabetics are more prone to developing coronary artery disease. So diabetes affects the carotids, affects the coronaries, affects the arteries of the kidneys, affects the arteries in your eyes. So ophthalmic artery and the small arteries within the eye itself, small vessels in the hands, feet. So a sonographer is able to differentiate between a normal and the patient with stage 2 diastolic dysfunction by all of the following except. So the reason that obtaining a resting E to A ratio is incorrect is because they will look exactly the same if the patient's resting. So at that point, we would not be able to determine, the difference between a patient who has a normal, mitral inflow versus someone who's got stage 2 or that pseudo normalization for diastolic dysfunction. So in order for us to be able to differentiate, we need to have the patient perform Valsalva maneuver while Doppling the mitral inflow. So then we'll see that E to A reversal. So during Valsalva, it will revert to a impaired relaxation where we have the little e and big A. We can also obtain tissue Doppler of the mitral annulus. So doing tissue Doppler will help us to be able to differentiate between a patient who has a normal diastology versus someone who has stage 2 diastolic dysfunction, as well as Dopplering our pulmonary veins. So those would be, some of the key ways that we can differentiate between patients with diastolic dysfunction and versus a patient who's normal. So we can Valsalva, having Valsalva when we're Doppling the mitral inflow, do tissue Doppler. We can see the differences in tissue Doppler between normal versus stage 2. And then we can see differences in pulmonary venous flow in patients that are normal versus they have stage 2 diastolic dysfunction. Mitral regurg is a common finding in hypertrophic cardiomyopathy due to, so this is due to systolic anterior motion of that mitral leaflet. So in HOCM, most common type is going to be our asymmetric septal hypertrophy. So that causes our LVOT obstruction, which causes almost like that suction effect, pulling up that anterior mitral leaflet into the LVOT, and that will lead to mitral regurgitation. If this had said dilated cardiomyopathy, then that could be due to dilatation of the chambers that will result in mitral regurg. So sarcoidosis is one of those infiltrated diseases that's associated with restrictive or infiltrative cardiomyopathy. Again, it's amyloidosis, number one. Other causes could be sarcoidosis, which is another autoimmune inflammatory disease, as well as hemochromatosis, glycogen storage disease. So pulmonary valve stenosis, this is going to be usually considered, or it's usually going to be a congenital lesion. So it's associated with, congenital heart defects. It's going to be something that the patient's born with, some sort of malformation. An acquired lesion is something that kind of develops over time. So, the patient acquired this lesion over the course of their lifetime. So that's incorrect. It's typically not a hereditary thing, it's not something that gets passed on, from person to person. So it's just, unfortunately, congenital malformation during the embryological portion of development of the heart. The left ventricle remodels and takes on a more spherical shape in which type of cardiomyopathy. So this is that dilated cardiomyopathy with the sphericity index. He's right. He's right. Everyone got Epstein's anomaly. Everyone got all the prosthetic valve ones, right? Disadvantages of mechanical valves when compared to bioprosthetic valves include all the following except. So the only one that's incorrect is that mechanical valves are less durable. So mechanical valves are more durable. So when assessing a prosthetic valve, a sonographer notices perivalvular regurgitation. So with this, the main thing that you should be concerned about at this point is dehiscence, or that separation of the valve from the annulus where it's sewn in. So we said, that these prosthetic valves, they typically have, some degree of regurgitation and stenosis with them. But when we see perivalvular or valve or regurgitation around the periphery of that valve, outside the valve annulus or around that valve annulus, then you need to be concerned about dehiscence or separation, because that is considered, a critical emergency. So like, so if I see, regurgitation coming in, from the sides near that annulus, coming back, something like that, then I would worry about, that valve potentially starting to separate from where it's sewn in, from that sew ring or from the annulus. So that would be something that's considered, perivalvular regurgitation. So if I have, regurgitation, say it's like, a double tilting disc or whatever. So if I have, central regurgitation jets, something along those lines, that's fine. That's normal. We just have to kind of understand which valve it is, what the manufacturer is, the size of the valve, and, compare it to previous imaging to determine if it's getting worse, if it's something new, progressing, to determine, if it's of clinical significance. But anytime you see perivalvular regurgitation along that periphery near the annulus, then that's something that should really start raising red flags and should be considered a clinical emergency. In addition, endocarditis. So endocarditis typically is going to affect those valves, those valve leaflets. So you'll see the vegetation is developing along the valve itself, and that would create, again, regurgitation that is seen more central as opposed to along the periphery. Something to also maybe potentially consider would be the development of like abscess formation, potentially along, the annulus in that sew ring. Annulus formation, abscess formation could potentially eventually lead to dehiscence, because you'll get a weakening of the sutures where it's sewn in, a weakening of that annulus as a result of an abscess formation. Calculate aortic valve area using continuity equation from the following measurements. So continuity equation. So your numbers on your LVOT have to equal the numbers for the aortic measurements. So if I look at my numbers here, 2 times 50 equals 100. So I have 100 on one side of the equation. I have to have 100 on the other side of the equation. So I need a number that's going to multiply times 200. That's going to give me 100. So I have to divide it by 2. So 0.5 times 200 equals 100. If that's one way you want to look at it. Or another way, if you want to look at it too, I have a small LVOT, VTI number, and this is a larger VTI number. So in order to have an equal, like, I'm going to need a smaller area to kind of balance out that equation. Or you can kind of just do your math, like your division. I don't know. How did you guys kind of like tackle this question to kind of break it down when you're doing your math? Did you guys make an equation? Or did you?
Yeah, I just like remember the equation
Yeah.
and plug it in.
My son hates me because I always just kind of do math in my head. I look at it, I'm like, oh, it's 0.5. Like I'm doing all these. I think I have a little touch of not autism. Yeah, autism. I guess I'm on the spectrum. I do all these math problems in my head and it drives me crazy. But anyway, like just remember that, these numbers have to equal that number. So like what you get on one side of the equation has to equal what you get on the other side of the equation. So if you're multiplying this times that and it doesn't equal what this is, your answer is wrong. So you go back and, give me a different answer. Give me another answer. Yeah, so you messed up your math somewhere. So this one, just looking at your velocities, 320. So that doesn't quite meet that greater than 4 centimeters per second. This is in 4 meters per second, I mean. So this is 320 centimeters per second. So if you convert that, it'd be 3.2. Or what they measured? They measured 3.3 actually, if you look it over here. So I'm sorry. And then also the mean pressure gradient, again, falls into that moderate category as well. It's almost close, but not quite. Catherine might have called this severe, right? So this is good. Showed up bicuspid aortic valve. Sonographer notes holodiastolic flow reversal in descending thoracic aorta. So this is an indication of severe AI or severe aortic regurgitation. So that's one of the things that we'll look for in terms of determining the severity of AI or aortic regurg is the presence of holodiastolic flow. So throughout diastole, we see a flow reversal in the descending thoracic aorta. So we could see that when we're doing suprasternal notch potentially, or even potentially imaging, potentially in 2-chamber, apical 2-chamber. Sometimes we could see that descending thoracic aorta. Or if you just want to, again, just go with your transducer, subcostal, and you could see descending thoracic aorta that way as well. So when we do our IBC, just kind of tilt over to the left, you could see descending thoracic aorta there. You can put your color and Doppler on and test to see if you see holodiastolic flow reversal. So all of the following could cause acute MR, except. So this is all of a sudden patient develops mitral regurg, so sudden onset. So for sure, endocarditis is something that can cause acute onset of mitral regurg. So again, patient, all of a sudden develops an infection on that valve. They develop, a vegetation. That vegetation will typically cause mitral regurg. So again, that's one thing to also remember about endocarditis versus a papillary fibroelastoma. Your vegetations or endocarditis will typically have regurgitation associated with it, while the papillary fibroelastoma does not. Patient can have blunt trauma to the chest. So if they also get hit in the chest, that can cause, potentially separation of that valve from the annulus, could cause potentially rupture of the chordae, rupture of papillary muscle for sure. If rupture of papillary muscle could also be due to trauma, could also be due to acute infarct. If on here was also, acute infarct or ischemia of the LV, that could cause acute onset of mitral regurg as well. MAC or mitral annular calcification, that's a slow process. So again, think of it, you're developing calcified plaque on that valve. that plaque isn't going to develop overnight. So it's not going to be an acute process. That's going to be more of a chronic condition, something that happens slowly over time. So particularly on the early onset of mitral annular calcification, they may not necessarily even have mitral regurg at that point yet. So these were our pictures. Are they going to give me the clips? See if I can go in and get the clips now for you guys. So I'm gonna go back and look at the images for you guys, or those clips. We'll pull them up, but just to kind of go over this one real fast. So this here we have an M mode that's cutting through the mitral valve. So some of the things that we can see when we're looking at this mitral valve tracing, you guys definitely saw mitral stenosis. So you could see here obvious mitral stenosis. We have a very flat E to F, almost no A wave. So you can see that this, it's definitely a stenotic mitral valve. It also looks pretty thickened as well. In addition to that, in this segment, we see that that anterior mitral valve leaflet is being pulled up towards the septum here. So this is our intraventricular septum. We see anterior motion of that mitral valve leaflet. So that's going to be our SAM, systolic anterior motion. So diastole, systole, when the valve should be closed, the mitral should be closed. We see a sucking up of that. And we also see that this measurement, 1.8 centimeters, our first measurement here, is a thickened intraventricular septum. So this is also, when we compare it to a posterior wall, is an example of asymmetric septal hypertrophy. So we have a thickened septum that's asymmetric to the wall. So we have ASH, we have SAM, mitral stenosis. Yeah, good. Let's see. Let's find these clips. Any questions about any of that so far? Anything that we've gone over so far? Anything you guys want to touch base on or recap, re-go over? Like, hey, Dan, I really don't quite understand that. Can you explain it again? Let's see if we get these clips to play. Stop sharing. All right. So just kind of going through these clips again. So this first one, I tried to show a picture of a patient that had an infarcted wall segment. So the best way to kind of look at an LV to determine, which wall segment's infarcted is to not only focus on, the motion if it's contracting, but to see if it's thickening. So I can see thickening of the myocardium, along this. Does anyone remember what wall this is?
Is it lateral?
Lateral, yeah. So remember, we don't have an actual just lateral wall. Is it anterolateral or posterolateral?
Anerolateral?
Good. Yep. It's anterolateral. So we can see some thickening. We can see some thickening up at the apex as well. And then this septal wall, it's kind of just kind of going up and down, but it's not thickening. So this is a patient that has, a septal infarct. You guys remember which coronary artery would that be? So it's probably 2. So this basal portion of it is typically the right coronary artery. And then when you get more into this mid segment of that, that becomes LAD. So LAD going into the apex. So maybe right, and then maybe also LAD as well. So this is kind of like that transition zone. So this probably is going to be right coronary artery. That's, I would say for sure right coronary, because that basal portion is not doing anything. Could it be also LAD? Maybe. Maybe not, just because I see the apex, kind of okay. But anyway, that's going a little further. So this one we could see picture of a valve. We could see some regurgitation going on. We see 2 jets, a larger one here, a smaller one over here. But we see all this, what looks like shadowing and artifact on the other side of the valve. So this is a good example of a mechanical valve with all that artifact seen posterior to it. So we can't really tell what's going on, in this chamber due to all this artifact. We got definitely some shadowing here, a lot of shadowing here, get some dirty shadowing here, some shadowing, when you see the valve opening and closing. So that's a good example too of a mechanical valve. Another thing that we can use also to determine, if we're looking at a mechanical valve versus bioprosthetic is when we're doing our Doppler tracing of, inflow of the valve or Dopplering the valve itself. With mechanical valves, I kind of over exaggerated it a little bit, but you'll see very pronounced open and closure lines for the valve itself. So the valve will open, you'll see the flow, and then you'll get a very pronounced closure line. So these are opening and closure lines that are very pronounced with the mechanical valves, those metal valves. The bioprosthetic valves, we don't see that. Those are very pronounced opening and closure lines. So that could be another clue too, if they give you a Doppler tracing as well. So this one. So if we look at these 2 pictures from this patient, one is our parasternal long axis that we recognize. The other is our parasternal short axis. So we could see what looks like a very thickened interventricular septum. And we could see a very thin posterior wall in comparison. It's definitely evident when you look at the short axis view. So here's our interventricular septum, and then our posterolateral wall. So this would be a patient that has asymmetric septal hypertrophy or hypertrophic, hypertrophic cardiomyopathy. If that was another choice for Holcomb. So this is our tracing, another M mode tracing. So for this one, I wanted you guys to recognize mitral valve prolapse now. So here we have a nice E, a nice A wave. Got our nice pretty cat ears. So this looks pretty normal in appearance, but here when the valve should be closed, we could see a bowing back of looks like the posterior mitral leaflet in this case. A little bit for the anterior one, but definitely that posterior mitral leaflet bows back. So SAM, that leaflets are being pulled towards the septum. In prolapse, they're going away from that septum. So it's bowing back. So this would be also things associated with mitral valve prolapse, that mid-systolic click. So if you could see, the valves together, and all of a sudden you get that click and it bows back. So around, mid to late systole. So in this case, it's a little bit later, but again, around mid systole, you get that click and of that leaflet bowing back. And also something you should remember too, that mitral valve prolapse may or may not be associated with regurgitation. So there may not necessarily be regurgitation, with these patients. What's a condition, or what patients are more susceptible for mitral valve prolapse? Which patient population? Guys remember? Or what's a group of people that we associate mitral valve prolapse with? Marfan syndrome. So our Marfan's patients are more likely to develop mitral valve prolapse. It's people with those connective tissue diseases. So this next one, I tried to find a nice, as normal looking 4-chamber clip as I could. This one's got good, systolic function. Chambers don't look, dilated. They look pretty normal in terms of relationship of size. Nice bullet shaped appearance. You see thickening of, all the myocardial layers. So this one was showing patient long axis view and then short axis at the mitral valve level. So in short axis, you can see it's quite evident. You have thickening of the mitral leaflets, particularly that anterior leaflet. And long axis, you could see the hockey stick appearance. So this would be a patient that has rheumatic mitral stenosis. And you can really also appreciate how large and dilated that left atria is. So this is, all signs point to, a stenotic mitral valve. You have a big dilated LA. If you're ever questioning, hey, is this left atria dilated, compare it to your aorta, your aortic root. So they should be pretty similar in diameter. This aorta is way smaller than this left atria. So, this LA is, significantly dilated. This one shows that classic D-shaped left ventricle, or a flattening of our intraventricular septum. And a very large dilated right ventricle. So this is something that we could see in a classic sign that we could see with patients with severe pulmonary hypertension. So we associate this with pulmonary hypertension. This flattening of the intraventricular septum due to the increased right ventricular pressures. So this again was showing another patient with dilated cardiomyopathy. So you see a round spherical LV, very large chambers, reduced EF. This was a rupture of the intraventricular septum. So we could see blood going from our higher pressure left ventricle into the lower pressure right ventricle, crossing over that septum. So you can see that regurgitant jet kind of blood flow coming into the LV and then crossing over through that rupture in the septum into the right side of the heart. And then this was classic restrictive cardiomyopathy. So this is our biatrial enlargement. So you can see just how large these atria are compared to our ventricles. And ventricles, I tried to show that they have a preserved systolic function, and that this is, primarily a disease of diastolic origin, or diastolic dysfunction, or leads to diastolic dysfunction. Ultrasoundidiots.com. I don't know how I feel about that. So what do you guys see here?
Is that a bicuspid aortic valve?
Yep, definitely. So that's opening to that football appearance. So if this is a bicuspid aortic valve, what are some other things that we could potentially be concerned about? Like what would a bicuspid aortic valve be associated with? What could other things we could potentially see on echo? Because these are kind
The
of how like
aortic
the boards
coarctation.
coarctation. Yeah, I'm sorry. And what else? You say something
Uh,
else?
No, I just remember you saying like those young people.
Yep, coarctation. So this is, be associated with young people. So when so is this considered what kind of lesion now? So it's congenital, but like, what else? Trying to think like how to word it. I'll just say it. So, bicuspid aortic valve is considered, a stenotic lesion because the opening, the valve isn't opening properly. So it's creating some degree of aortic stenosis. So this would be, the most common cause of aortic stenosis, or most common congenital cause of aortic stenosis, something that we see in young patients. So if it's aortic stenosis, you have to kind of attribute all the same things that you think of a patient that has degenerative aortic stenosis. The same still applies to congenital aortic stenosis. So with aortic stenosis, we can also potentially see dilatation of the aortic root. We can also, potentially see left ventricular hypertrophy. Could eventually potentially lead to left ventricular chamber enlargement as well, but definitely hypertrophy first. So just keep those things, in the back of the mind. So definitely, aortic root dilatation, because you have that post-stenotic dilatation that's associated with it. Coarctation, again, there's also association with coarctation, because this, happened during the development, embryologic development of that aortic valve and aorta. So you also worry about coarctation as well. Because that aortic trunk is developing at that same time. Good. Bicuspid aortic valve. You did? All right. Perfect. Thank you. I'll see you later. All right. What do you guys see on this one?
Would that be tamponade?
Yep. Cardiac tamponade. What gives it away?
RV collapse? Or RA collapse, I mean?
Yep. I definitely see RA collapse. Looks like also a little bit of RV too. What else do you see? So
There's an
so you know it's
effusion.
I'm sorry?
There's an effusion?
Absolutely. Yep. And just kind of looking at this, I would assume that it's probably going to be circumferential. I see it, in this view, I could see it over by the left ventricle. I could see it, down on the right side of the heart. Can't really see what's going around the right ventricle too well, but, I see fluid on the left side of the heart. I see fluid on the right side of the heart. So this is probably, a circumferential effusion. So you see that collapse, you could see, the effusion, the obvious fluid. So you automatically should be worried now about tamponade. Rachel, if I'm Dopplering this patient's tricuspid valve during inspiration, will the waveform be larger or smaller during inspiration on this patient's tricuspid valve?
Hold on, wait. Tricuspid inspiration is smaller.
I
I forget.
increase. I increase.
Oh yeah.
So just memorize right side of the heart and then flip it. Like, don't stress yourself about right and left. If you remember right side of the heart, I, inspiration, increase, I. The tamponade. Inspiration is going to increase and expiration is going to decrease. So just think about it. Everything's kind of backing up, slowing down now. So this patient probably will have decreased, systemic blood pressure. There's less blood flow getting to that left side now. So these chambers aren't filling well. So that's, again, returning less blood to the left side of the heart. This patient's going to have lower systemic pressures. They're going to have weak pulses. Stuff's going to be backing up now, in that IVC and SVC. So they could have potentially, jugular venous distension, dilated IVC, potentially dilated hepatics. Ulcus paradoxus, we're gonna see. Oh, what happened? What did I do? What did I do? Where is it? Is it sharing? Why are you pissing me off? You guys able to see this one or is it not sharing? Like, I can't tell. You
I
guys-
see
you
it.
guys- You guys see it? All right. I was like, why does it keep disappearing on me? What's going on there? What do you guys see on this one?
Would this be mitral annular calcification?
No, probably not.
Is it like, I mean, I'm not sure, but
I'm
is
not
it like,
seeing really shadowing on the other side of the valve.
Oh, okay.
is it like regurg from the aorta, like making it shut? Or am I seeing it wrong? Like, it looks like the mitral valve is like not opening good.
Yeah, it's not opening well.
I
It's
don't know if this is
not,
right, but
I don't know
think-
if it's necessarily regurg.
I just thought I remember seeing something in one of the PowerPoints that looked like this, and I can't remember, but it was like one of the hypertrophies.
Well, what do you guys see? What's obvious? Like, what's the one of the first things you?
I mean, I do agree that I feel like the mitral valve isn't working properly, but I'm
Yeah,
not
it's
sure
not
why.
opening properly. Good. Yeah, I agree. It looks stenotic. It's not opening right. What else do you see going on with that mitral valve?
I mean, it's definitely regurg in
Good.
the
That's
mitral valve.
important for sure. There's regurg going on there. So we have a stenotic mitral valve. What's the most common cause of mitral stenosis?
Rheumatic heart disease.
Yeah, rheumatic. So that's kind of taking on that hockey stick. This is probably rheumatic. I wouldn't say it's MAC, mitral annular calcification, because I really don't see a lot of calcification causing shadowing. So in patients with MAC, you'll wind up with posterior shadowing because of those calcifications, particularly if it's on, the posterior annulus or that anterior annulus. So that calcification is going to start on these annuli and cause shadowing. I don't see any shadowing going on here. So I wouldn't say it's MAC. So then my other options for mitral stenosis, the most common one is going to be rheumatic, mitral stenosis, hockey stick. And I definitely see regurg. There's one last thing I can kind of diagnose off this picture. I'm just kind of eyeballing it though. So I would say that the left atria is dilated as well. So again, like your aortic root and your LA should pretty much be like 1-to-1. So they should be, pretty similar in terms of diameter. This LA looks a lot wider than that aortic root. If I kind of use my little numbers, I got 1 centimeter, 2 centimeter, 3 centimeter. So like a little over 3 centimeters. So it's getting dilated. But the main thing is I wanted you to realize, yes, that is definitely a stenotic mitral valve. And I see mitral regurgitation. Just kind of look at that, be like, yep, I definitely see the MR. And that looks pretty stenotic too. It doesn't look like it's opening right. So mitral stenosis. This is taking on that hockey stick appearance, thickened leaflet. This one's got a bunch going on. All right, Rachel, one thing, I'll let you go first. What do you see? What's something you see?
The mitral valve.
For sure. Yep. What about it?
It's not opening
Good.
properly.
That means mitral stenosis. Good. You're on a roll. What else do you see, Rachel?
I feel like the aortic valve is stenotic too.
Absolutely. Looks like crap.
Yeah.
It's barely opening. Definitely. What else? Come on. You got this. You're a cardiologist today. Something else we see.
So I don't really know what it is, but there's something going on in the left ventricle, or the right ventricle, I mean.
Right ventricle? Yeah.
I don't know what it is, like on the bottom.
RV or LV?
The right ventricle. Am I
Right ventricle? Yeah.
Yeah, like at the bottom. You see what I'm talking about?
Yeah, you might be picking up a cord or trabeculation, but it looks huge, right? It's big. Shouldn't be that big. That's a big dilated RV. Like we typically only see a small little segment. We're seeing a big RV on this guy. You know, maybe that might be moderator band machine. I don't know. Could be. Not sure. Could be a piece of cord. What else? What else do you see? You got this RDCS.
Yeah, I don't know.
Oh, you said you said something, you see something RV. What about LV? Does it look normal?
Um, I mean, because you said that, no. I feel like I can't really see that much that's going on. It's like not really filling.
How's it contracting?
There's like a lot of movement.
So us says, yeah, not a lot of movement. You said it exactly. So that's one of the first things is when us going into an exam as echo text, the first thing the doctor is going to want to know how is the heart beating? Like how's the LV contracting? So you look at that right away, that doesn't look like it's contracting very well at all. And we know what our hearts look like when we're doing our echoes here. So yeah, absolutely. So first thing you look at is that LV. Oh, man, that doesn't look like it's beating very well, man. That EF looks really terrible. That posterior wall, like, really, it's not even doing much of anything. That septum's kind of just bouncing there a little bit. I don't even know if that septum's thickening a little bit, but who knows? Like the base of that septum really isn't doing much. Maybe it's just bouncing because this, RV is so big. This guy's got a real bad EF, No, you're doing good. I mean, you're seeing these things. You see anything else, Mary? All right, comment.
Did we already say the left atrium?
No, yep.
Okay, it looks dilated to me.
Definitely, absolutely, it looks huge. Left atrial dilatation.
I can't tell if, like, is that like calcification on the cord in the left ventricle? Like those bright, yeah, those,
Like there.
yeah.
Might just be like the way we're clipping the cord. The cords typically don't, get calcified.
Okay.
I mean, this definitely looks calcified. Like I see it's echogenic. I mean, I'm not really getting that much shadowing, but it's very echogenic. And this looks like maybe some calcification here now. Like compared to that other one, like this definitely looks a lot brighter. But Dr. Barrios, what would we be worried about? One thing we'd be worried about with this patient. Something we would be worried about encountering.
Like, what's it called? Like thrombus development in the atrium because it's dilated. And
Definitely.
I'm thinking if we were to go short axis, it'd probably look like pulmonary hypertension, like a D shape left ventricle because of the right ventricle.
Yeah, it's big, it's dilated. Good. Dr. Starring, anything else you want to add?
I don't think
I'm gonna
so.
start calling you all doctor. You're all doctors to me now.
I don't think so.
I don't think so. Yeah, I mean, we pretty much nailed almost everything. I would also be worried about the potential for left ventricular thrombus because this EF looks terrible. So I don't know, like, maybe this guy's apex is completely down too. There's a potential for LV thrombus as well.
What about aortic dilation because of the
Yeah.
stenosis?
Yeah, the aorta looks dilated as well. Like if I kind of use my little calipers on the side here, I got 1, 2, 3, 4. So this is like, looks pretty dilated as well. Let's see, we got 1, 2, 3, 4. Yeah, so this is almost 4 centimeter aorta. That's dilated. So if I put this on the quiz and you guys say this is normal, I'm just, you're not even gonna see me the next day. What do we got?
Don't take it hard if I mess up another math one. That's just me. It's not you.
I'll do easy math. Try and make it easy.
Could we possibly go over the quiz we took today, or is it too early?
No, we can do it. That's over here. Most common benign tumor of the heart is going to be our myxoma, more specifically left atrial myxoma. They can also appear in the right atria, but by far more common in the left atria. Dilatation in the aorta can be primary or can be due to secondary causes like hypertension. I should have probably put systemic hypertension on there. Differentiate between pulmonary hypertension. But systemic hypertension is something that will cause dilatation of the aorta. Pulmonary hypertension is going to translate that pressure to the right side of the heart, so it's not going to affect, aorta. So that's not going to cause aortic dilatation. Again, everything just kind of runs backwards. Vegetations need to be how large to be seen, so that's greater than 2 millimeters. Good. Most common benign tumor found in children. That's going to be our rhabdomyoma. Marfan syndrome is a connective tissue disorder. Someone should be aware of and measure what part of the heart, aortic root, and then the ascending aorta. Again, Marfan's, we're worried about aortic aneurysm, aortic dissection. Those are the two biggies. We're also worried about mitral valve prolapse with these patients as well. Papillary fibroelastomas usually affect the aortic and the mitral valves, left side of the heart. Right-sided endocarditis is usually found with intravenous drug abusers. Myxoma is most commonly found in the left atrium. Sinus valsalva, most aneurysm most often arises from the right coronary sinus. So we can oftentimes see it protruding into the right atria. Most common malignant cardiac primary tumor is going to be our angiosarcoma. Benign tumors appear well circumscribed, while malignant tumors appear to infiltrate the tissue of the heart. Good. Aortic dissection is a tear in the intimal layer of the heart, or of the aorta, sorry. Angiosarcoma is most commonly found in the right atrium. Good. An aortic dissection is often difficult to ascertain which is the true lumen and which is the false lumen. Which of the following statements is false when describing the true lumen? So that smoke will often appear in that false lumen. Because if you think about it, blood flow is entering into that false lumen, really has no place to go because it'll reach the end of that dissection. And then it could potentially reverse, or it can start to, coagulate and pool, form into clots, become stagnant. So that's why you often wind up with the development of thrombus within that false lumen. Primary tumors are more common than metastatic tumors in the heart. So that's false. If we see a tumor in the heart, more often than not, it's going to be metastatic disease. And our most common metastatic tumor in the heart is going to be melanoma, skin cancer. Complications of aortic dissection include all the following except. So that's going to be pleural effusion. Good. You guys got all the rest. Endocarditis is an infectious process that alters the valve structure and function and rarely causes regurgitation. So that's false. Endocarditis commonly causes regurgitation. So that's something, again, that we can use to potentially differentiate endocarditis from some sort of valvular tumor like papillary fibroelastoma. Predisposing factors of left ventricular thrombi include all the following except. So we want things that are going to either cause dilatation of the LV and reduced LV function, systolic function. So the ones that will fit those bill, we can worry about potential thrombus development within that aneurysmal segment of that left ventricle. Patients that have recent myocardial infarct, they would have a reduced EF that could potentially develop thrombi, particularly if it's an apical infarct. And then patients with dilated cardiomyopathy for sure. So the one that doesn't fit that bill would be restrictive cardiomyopathy, because in this we typically have sustained or preserved, better word, systolic function. So this will not create that conducive environment for developing ventricular thrombi. So had this said atrial thrombi, for sure, restrictive cardiomyopathy, definitely, that would fit the bill. Which of the following can mimic left ventricular apical thrombi? So that's our hypereosinophilic syndrome. So that's that mural thickening seen up at the apex. That's associated with laminar thrombi. Aortic transection. So again, you guys all got this right. It's due to blunt force trauma to the chest. Pulmonic regurg are more common than tricuspid regurg. Pulmonic valve vegetations are more common than tricuspid. That's false. More often than not, we'll see it on the tricuspid. We're talking right side of the heart. Conditions that lead to stasis of blood and left atrial thrombi include all the following except. So that's going to be hypertrophic cardiomyopathy. With hypertrophic cardiomyopathy, we typically don't have dilated chambers. So good that you guys recognize AFib, definitely associated with left atrial thrombi and stasis of blood. Restrictive cardiomyopathy, definitely you're going to have biatrial enlargement, which will lead to stasis of blood and left atrial thrombi development. Dilated cardiomyopathy, definitely. So common source of thrombus formation in the right atrium involves indwelling catheters and pacemaker leads. That's true. The most common bacterial organism for endocarditis is this Streptococcus viridans. And this was kind of matching the aneurysms. So I probably have to go back in and kind of grade this manually. But anyway. Anyone remember? Your dissections. So DeBakey 1 is going to be both anterior, ascending and descending. So this is going to be your DeBakey 1. Both includes the anterior side again, ascending and descending aortas. Stanford A. So that will include both the ascending and descending aortas. So it can be just ascending, or it can be ascending and descending. DeBakey 2. This involved just the ascending aorta. Stanford B. So these, you guys both get credit for this. So like I couldn't have really differentiate. So I'll go back, so if you got this marked wrong for this person, you'll get credit for it. So Stanford B involves just the descending aorta. Good. Again, same thing, DeBakey 3. So anyone who picked, this choice and this choice, they're both correct. So DeBakey 3 is just the descending thoracic aorta. So for DeBakey, my little acronym for 1, 2, and 3 again is BAD. So type 1 correlates with the B for the bad, which is both. Type 2 is the A, ascending. And then type 3 is D, descending. That's my little acronym for remembering DeBakey dissections. How do you guys feel? I know you're stressed about physics. The DMS girls were in here in Godwell. They were talking physics.
Yeah, it's like 103 questions. So now I have to get through that study guide he made. Get all them together. I'm not gonna lie, I'm a little nervous for all these tests. I'm not gonna lie.
Well, there'll be some bonus questions on our Echo one, and you guys got points banked for vascular, so I don't anticipate. Guys, you're all smarter than you think you are. You guys give yourself some credit.
It's like a thing I do. I have to envision myself failing and then I pass.
God,
My good luck charm.
well,
So like question for
Sure.
Echo.
Sure.
Will the questions be like, are you gonna like kind of like,
pretty much similar to what we've had so far.
yeah, or is
Kind
it
of-
gonna be
I'm
like
kind of
really
pulling
unique?
from, I'm kind of pulling from the tests that we've done so far.
Okay,
Like, I'm not, all the pictures have been on like either D2L, like for the mass, cardiac masses. To be honest, I'm probably just gonna like, show like papillary fibroblastoma and like vegetation and myxoma. I mean, those are like the three big ones that will probably show up on the registry. I'm sure they're gonna throw a myxoma on there on the registry, so I want you guys to recognize myxoma. I want you guys to recognize papillary fibroblastoma. They may want you to recognize Land's accessorants. That might be potential one. I'm trying to just think boards, preparing you guys for boards. Like they're not gonna have you be like, oh my God, what does a lipoma look like? Angiomyosarcoma, like, they probably more just want you to know the fact that, it's the most common, primary. Because again, those things are so super rare.
yeah, I would appreciate that because I was like super ready for that today, and then like the Stanfords and the DeBakey's really got me. I was like, should have looked at that more.
Yeah, they like the Stanfords and the Bakeys. She actually told me like that stuff was on it. Yeah, I'm glad we went over it too, like her and I. Then the other thing too is I'm gonna have labeling wall segments. So I want you guys also to, know your wall segments for your parasternal short axis at was it at should we do mitral? Which level should we do? Should we do mitral valve level? Or should we do at papillary muscle level? Let's see. Which one's better? I want to see what I have for my pictures. Hold on.
And I'm like assuming we need to like make sure we got our values down right for like stenosis and
Yes.
mitral stenosis and all that. Okay.
Yeah, mitral stenosis. So pressure half time, you know, 220, greater than 220. Aortic, yeah, and then aortic, your valve, so mean pressure gradient too for mitral stenosis, pressure half time for mitral stenosis, your valve areas, which you guys know, you guys know their valve areas by now. And then aortic valve, same thing, mean pressure gradient, the aortic valve velocities for stenosis. Yeah, so we're gonna do short axis, labeling the wall segments at the papillary muscle level. That's the one I had. I mean, I guess it's the same as whether you're at the mitral level, and it's the same, but that's the picture that I had. That one, and then what did we have? We had and then we had the apical 3-chamber. Actually, no, actually, nah, we'll just do that one. I'm debating between if I should. Yeah, we'll just do the one. Summer session, I'm gonna grill you guys on wall segments because you guys need to know these like without even thinking. So down the midterm, we'll just have the short axis papillary muscle level filling in the wall segments. That's gonna kind of be your fill-in for this test.
Is it like 100 questions too?
It's gonna be out of 100 points. Some of the questions are gonna be like worth more. So yeah, I guess essentially, yeah.
Oh, question.
Yes.
You know how we did the teacher class, the TEE views? Should we like look over that too?
No.
Oh, okay.
No TE views on this. No.
All right.
No, that's end of summer stuff. After we get through the congenital, we're gonna start. We're gonna be playing doctor. We're just gonna like do case studies and what do you see? What can go wrong? What do we expect? Because when you can start looking at an exam, and look at these images and knowing, what to expect, what could happen, what cannot happen, the boards like to do that too, you know, like, all right, I have this patient, this is what's going on. What is not a possibility? So like, yes, that can happen. Yes, that can happen. Yes, there could be this. No, that one definitely cannot happen. And they want you to be able to kind of do that for each thing. So you guys are gonna be surprised by the end of the summer and be like, all right, we kind of just put everything together now. So we'll spend the first part of the summer just doing congenital heart disease. And then it's gonna be all case studies and calculations. And then you get 8 months to forget everything and try and sit for your boards. Nah, I'm gonna be giving you guys practice registry questions through the rest of second year for you guys to be, keep practicing and studying Echo. So
I just need to be done with physics.
oh yeah,
and
no,
life would be a lot
once it's
easier.
done, yeah. I don't blame you. Blame you. All right, well. Have a happy Mother's Day, Juliana, and happy Mother's Day to the rest of you. Be nice to your mothers. It's supposed to
Yeah,
rain all
man,
weekend.
that's some real stuff. I know.
Yeah.
This weekend's gonna be so ugly.
Yeah, it's
Oh
gonna rain
well.
all weekend, so like try not to piss them off. I'm already starting Mother's Day on a bad note. Like I accidentally took my wife's cell phone to work. Like I
Oh.
was trying to be nice and bring it down to her from upstairs, and I got to work to open my office, and I reach in my pockets and I pull out two phones. I'm like, oh Jesus. So like, like she was like using my stepson's phone to try and call it to try and find it this morning. I could hear him like, I'm calling it. Like, and I'm like, hello. I'm calling your phone. You can't hear it. Like, I'm like, guys, I'm on the phone. I'm like, check your text messages. Anyway.
That must be like a meeting or something because Max just cracked my phone. So that's my Mother's Day.
Um,
What a gift.
that stinks. You gotta get the real, like, I know they're ugly, but like, my kids like destroy it, so I have to get those serious, like, protective cases, otherwise forget it.
Yeah, I wanted it to look pretty again. That was my decision, so that's my bad. So learn my lesson.
Dan, what should I do for Monday then? If Eden Hill, there's not gonna be a tech there.
She didn't even email me like about any of this, like that's,
Yeah, she didn't. I checked my email and I don't have anything either.
she just spoke to you guys.
Marissa said that she called her.
Like 5 minutes before class started.
She called her.
Yeah.
So we could, what are we doing Monday? I mean, it's up to you, wherever you feel like you want to go.
Oh, okay. Is anybody gonna be at Riddle?
I don't think so, right? No one's at Wordle, right?
Nah, I just finished with them.
Okay, just because it's another vascular site.
Sure. Yeah, Monday I can't, unfortunately. Oh, can I make it Monday? What's going on Monday? Let me see. Yeah, we'll save that for summer because I don't even have like all my logins and everything yet. But yeah, if
Okay,
you want to go to Riddle, I'll tell Nicole.
okay, cool, thank you.
All right. Sounds like a plan. All right. Well, have a good weekend, ladies. If you guys, think of anything while you're studying, I'll answer.
Actually, I have one more question.
Sure.
Would you be able to open up the vascular quizzes for us to be able to like view the answers for that to study from?
Or let me see. Figure out how to do that. Yeah, I figured out how. Okay. Yeah, let's see. Sure question, yes. Sure questions, answer. Sure question answers. All questions with user responses. Huh. Um, can you guys go on to the vascular on D2L and try quiz 3 and see if you can see it? I'm just kind of playing around. I've never like opened it up like that again, but I'm not sure if it's gonna work.
Yeah, I can see quiz 3.
You can see quiz 3. All right, cool.
Yeah.
All right. Yeah, so yeah, you got it then.
Okay, thank you so much.
All right.
All right, have a good weekend.
All right, you too.
Have a good weekend. Bye.